Hi, I'm Jens Chapman from the Seattle Science Foundation. It is my great pleasure to introduce the fourth speaker in a four-part series on making a real difference for our patients with spinal cord injuries. Making a practical difference in terms of surgical intervention has been a long-held dream. It is my pleasure to introduce you to Dr. Jim Harrop from Jefferson University and the Rothman Institute in Philadelphia. And he's going to talk about early versus late surgery and a specific type of a spinal cord injury, that is central cord injury. Jim, please take it from here.
Well, thank you very much, Jens, and I'm honored to be following these great speeches in front of me. It's kind of humbling listening to all the great talks. We've learned about pharmacology, radiology, and biomarkers. So I'm going to try to pull things a little bit together, and after I give my disclosures, again should not influence the talk. And going forward, I'm going to give a very quick talk. We're going to go through and we're going to look at the, as an overview, we're going to go through and we're going to look at the timing of surgery. We're going to quickly go over a case study, then we're going to look at some animal data, go over a quick literature review. We're going to talk about probably the best research we have about the timing of surgery, which is the Diagnostic study, which Michael mentioned earlier. And lastly, we're going to go through central cord injury. And unfortunately, there's a paucity of literature on this, but we're going to see what's available and what we got. So this is a very common scenario, probably encountered it once or twice a week. I'm sure most in the audience also agrees with this. 67-year-old woman comes into your office. She fell. Usually they have probably some baseline myelopathy behind this, but she was walking and she tripped over a rug, fell forward, and hit her head. She had immediate burning in her hands with weakness. Unfortunately, a lot of times these patients are actually missed. They go home, and then they follow up in your office. And when they see you and you examine them, they usually have weakness in their hands intrinsics, their distal motor, otherwise have a normal exam, tend to have dexterity issues, loss of pinprick, and a lot of times they'll have hyperreflexia, increased tone, and maybe a Babinski, but unlikely. So as we go forward, we get, in most of these patients, we get a CAT scan looking for what? A fracture. And again, this is one of the problems in our system is there is usually not a fracture. It's usually a spondylitic canal. If you're lucky enough to get the patient, as in this patient who had an MRI, you can see they tend to have a very spondylitic stenotic canal where they were probably walking around without much difficulty. They then get a hyperextension and a subtype of a spinal cord injury and come in to see us. So why is this a problem? This is a study where we looked at our population and we discussed geriatric patients at the age of 70. And what did we find out? We found out that there was a 300% increase in 20 years over spinal in this age group, which I'll tell you right now, we did this in 2005, and this number keeps on going up. And if you look to the slide to the right, what is the major problem? It's usually falls. And it's usually falls probably due to undiagnosed cervical myelopathies. So what happens when you have a spinal cord injury? And you heard some great talks earlier today, or early this evening, and it's interesting. If we think you just have a mechanical injury to the spinal cord and you're done, then you can hang up. The conference is over. But I think most of us think there's a secondary injury. And Brian showed this with his biomarkers, and Shekar showed it with his MRIs, and Michael showed it with his responses to pharmacology. There is a secondary injury, and the question becomes is when do you interact, how do you interact, and how do you make the best for your patient? Well, you know, again, interestingly, if this was a stroke and I told you your patient came in with a unilateral weakness on one side of their body, there wouldn't be a question. It would be get this patient to the MRI machine, get them TPA, and help them as fast as possible. There seems to be not that rapidity with neurologic injuries when we're talking about spinal cord injuries. And I think one of the goals today is for us to step back and think about spinal cord injury as an acute needed neurologic problem. So let's go back and think about early surgery. And this is not that long ago. 1950s were some of the first animal studies with spinal cord injuries in animals. And what did they show? They showed two things. One is the more you press on the spinal cord, the less likely it was recovery. And two is the earlier you took off pressure off the spinal cord injury, the better the recovery. And does this apply to humans? Well, Michael Fehlings and his group actually did do a retrospective review of this, and what they found out, and this was actually back in 2010, they found out that, yes, there is some literature out there, not great literature. There wasn't great data supporting that you get a neurologic recovery, but you did show that it was safe, you had reduced length of stay, and you had reduced complications if you operate on patients early. One of the problems with this is, and you're going to see through the trials today, all of us, when we were talking about early, we define early as less than 24 hours. If you go through the older literature, meaning 10 years ago, early was up to 5 days, 72 hours. And I think what we're seeing is earlier is becoming earlier because the sooner is the better. And so most of us believe that probably that 24-hour injury mark or surgical intervention, we might want to even be earlier than that. So what about a meta-analysis by LaRose and their group? They did a very interesting study where they looked at complete spinal cord injuries, and what they show. And if you operated on them late, they actually did worse. If you operate on them early, they tend to have approximately 20% improvement, which is almost a 40% improvement than when you did them late. How about the incomplete injury patients? If you operated on them, if you didn't operate on them, what happened? You had about a 50% recovery rate. If you operated on them late, didn't really change anything, you probably prevented a late deterioration on them. But if you operated on them earlier, you tended to get, almost again, a 20% increase in recovery in this population. And again, Michael led this charge, and we applaud him greatly. Published in PLOS One is PLOS One, and that was the STASCA study. The STASCA study looked at a large group of spinal cord injured patients, and what they tried to say was, if we operate on early, and again, early was defined as 24 hours, and interestingly, even the late group was 48 hours, which some people would consider early. So it's early versus super earlier, but at the time it was super earlier. Now we probably wouldn't say it is. And what they showed is that if you're going to get a 2-point recovery, meaning going from an ASIA A to an ASIA C or an ASIA B to an ASIA D, you had a much greater chance of doing that as if you were in the early surgery group. So now we're going to switch gears a little bit, and I was asked to talk about central cord injuries. The central cord injuries, and again, we sort of heard it out today, and Brian's sort of spectrum of patients is probably true. And I think the central cord injuries might be a different population. And I was asked to comment on, do I think that we should intervene surgically early in this population? So we have to go back again to our forefathers, and we credit Schneider with this at University of Michigan. He did a lot of the early works here. 21 cases, 10 fracture dislocations, not what we consider really degenerative central cord injuries. The interesting thing is, if you go back and review his papers, he suggested that you shouldn't operate on central cord injured patients because the morbidity was too high. So then we have to step back and we have to say, well, how did he operate on these patients? He actually would go in, they would open up the dura, they would then cut the ligaments, the dentate ligaments, move the cord over, and then do a transdural resection of the disc herniations and acutely traumatized spinal cord injuries. And shockingly, the patients did not have a great neurologic recovery. So I think hopefully our surgical techniques, our understanding of biomechanics, anesthesia principles, hypertensive therapy, which really hasn't been talked about, but is probably one of our greatest improvements in the last 20 years, has improved the outcomes from surgical interventions, and since then we've somewhat changed. The second thing I just want to talk about is is the central cord injury comes up with the concept that we're really organized very nicely, and if you get the center portion of the spinal cord get injured. This is a slide on the right where you look at Bunge's original work, and what they did is they plotted out the neuronal injury after a central cord injury. And the reason I bring it up is because not only is spinal cord injury heterogeneous, I also think we need to step back and think about, is a central cord injury really a central cord injury, or is it selectively knocking out different neurons? And you can see from this pattern that, yes, there's not only central, but a diffuse amount of spinal cord injuries, which selectively knocks out motor neurons. So when we have these patients, what do? Our options are quite simple. Usually we put them in a cervical collar, and then we try to keep their blood pressures up. However, again, the central cord injuries tend to be in elderly populations. Very rarely do you need to put them on blood pressure medications to meet arterial pressures. But then the next question becomes is, should you operate or should you not? And traditionally, there was you waited for them to plateau, and then you operated on them. In the 90s, Chen and Sontag, both out of the Barrow group, they looked at, could you operate on these people and could you do it safely? And there was definitely showed that you did not hurt patients with early intervention. The second thing is, as we go back, is there was a question of, should you operate on these people in general? Is medical therapy as good as surgical therapy? And these three studies pretty much said that, yes, there's probably a benefit to surgical decompression versus non-surgical options. Second thing is, should surgery be done earlier than later? And in these studies, probably the Yamazaki study is the better paper of all the papers, and it shows that if you're going to operate on these papers, you probably get a better neurologic recovery if you do them within 2 weeks' time. So with that said, in the same focus issue that Shekar was talking about, we actually did a focus review of surgical decompression for the central cord injured patients. Again, large series of patients, and we went through this, selectively reviewed the literature. And again, unfortunately, as in most spine cases, we don't have great literature. We're down to 9 papers. 3 were prognostic, 5 therapeutic, and 1 was both. And we went through them trying to understand, looking at, again, should we operate less than 24 hours, 1 day, or less than 2 weeks? These are the 4 questions we asked. Again, looking at the efficiency of operating less than 24, greater than 4 hours. Does decompression influence functional outcome? Is it safe? Is there evidence that early decompression has differential effect in different subpopulations? And lastly, cost effectiveness. And really what it comes down to is there wasn't a lot of great papers. The 2 best papers were the Lenahan paper, and again, and this was actually a subgroup analysis of the Staskis papers, but you can see 2 important things is not only did motor scores improve at 6 months and 12 months with a very nice confidence interval, but the FIM scores also improved. And this is Brian Lenahan's paper, and it goes through 73 patients out of the large Staskis patients, and as I showed before, at 12 months you get greater outcomes. The authors concluded that if you had very severely injured patients, you probably should operate on them early, as in the same hospitalization. If you had someone in Asia D who was neurologically at a functional recovery, you may be able to put them in a collar and do it at a later date. So with that, the recommendations of the paper was that it appears that if you have long-term neurologic outcomes compared to with delayed surgery, you suggest that you should consider operating on these people within 2 weeks with central cord injuries. 2 is early surgery was safe, and you should understand that there may be an improvement in neurologic outcomes with a decreased risk and complications, again, if you do it in earlier than a later time. And with that, I thank you.
Jim, thank you for this great lecture on one of the very important, very succinct subsets of spinal cord injury. Shekar, with your imaging technology. Can you see central cord injuries on advanced imaging?
Oh, absolutely. I think that's one of the low-hanging fruit in terms of testing the diffusion imaging technologies that are coming up both here and elsewhere. I think this is a natural model of recovery, spontaneous recovery. So this is an ideal condition to study in a longitudinal fashion. One of the things that Jim asked of Brian earlier was that, as opposed to getting a snapshot of a biomarker profile, was there some thought to what the longitudinal profile would look like? And that's sort of something we've done with imaging as well, to see, is there an optimal time to get a diffusion sequence, and how does that sequence at that particular time reflect prognosis? So, well, here you have a clinical condition that most likely is going to track towards spontaneous recovery. So this would be an ideal milieu to study diffusion imaging and how it changes. And that might actually help us not only define central cord syndrome from an imaging perspective better, from an MRI perspective better, but allow us to develop tools to sort of prognosticate other types of spinal cord injury outside of central cord syndrome.
Dr. Fehlings, as lead investigator for the Riluzole trial, do you see membrane stabilization being one of the great applications in this kind of a shear trauma that we suspect central cord injuries are? And secondly, spasticity, as identified by Jim, is one of the late big problems. How do you measure spasticity? Is this something that is currently being captured as a clinical outcome in prospective spinal cord injury trials like the many that you have chaired?
Well, thank you. Well, central cord injury is now one of the most, if not the most common subtype of spinal cord injury that we're seeing in westernized society. And this is a type of injury that has traditionally been thought of as having an excellent prognosis, and little intervention is required. But our knowledge on this is evolving. It's recognized that these patients roughly fall into two categories: those who have a severe presentation, so Asia C, or those who have a milder type of an injury and show kind of a more rapid recovery. Patients with severe central cord injury are eligible for enrollment in the RISCUS trial because we are including patients with cervical Asia C patients. And so we'll get an answer in terms of the potential role of a neuroprotective drug such as Riluzole in this patient population. Interestingly, however, conceptually, and there's some data to support this, a severe central cord injury may represent one of the optimal types of injury that could benefit from a neuroprotective intervention or other type of intervention. The reason is that we're targeting the secondary injury. So if we think about a high-speed accident where there's very significant trauma to the spinal cord, the primary injury can often overwhelm the effects of the secondary injury. We're trying to treat the secondary injury. But in the setting of a central cord injury, the primary injury is often quite mild. It's a low velocity fall, and there's an overwhelming amount of secondary injury. And so conceptually, neuroprotective drugs are going to play a role. I'm going to come back to some comments that Shekar Kurpad made, that the ultimate treatment for spinal cord injury will be combinatorial. Currently, we have early surgical intervention, we have intensive medical ICU care, and then we have structured rehabilitation. We're lacking treatments to alter the outcome in the form of pharmacologic treatments. Possibly methylprednisolone may have a modest effect. So to come back directly to your question, I think that central cord injury is actually an ideal patient population to study neuroprotective drugs, but it is a heterogeneous population, likely with different pathophysiologies, where biomarkers and imaging may allow us to discern these different subgroups to treat them optimally.
Thank you, Michael. Brian, currently, obviously, prospective randomized clinical trials are the gold standard for scientific insights. In the US, several large-scale, well-funded trials have famously failed because patients did not want to enroll. Over half of the patients in some landmark trials refused to participate at one point in time or another because of their own preferences in clinical trials. Your center has gained great credit for so many successful major trials, Central Court being one of them. How common is it, and why are there such differences in terms of successfully enrolling patients in prospective randomized clinical trials? Should we even abandon this concept, or should we hold on to this?
Well, I think that's it's a really great question, Jens, and I think that it's a question that probably people in the entire neurotrauma field are struggling with. I know they are, people, some of Andrew Moss's work in the brain injury field, considering other types of methodologies for answering these types of questions. You do put a big bet on when you do a prospective randomized study to evaluate a single neuroprotective agent. I think that the way in which we evaluate these types of therapies will probably evolve over time. The way that we do prospective randomized trials will evolve over time. So I'm not sure if we're right now at a stage where we could necessarily abandon them for large-scale prospective observational studies, which have great value, but also present different unique challenges. I think that it's great that our field is still pushing forward with novel therapies and also novel approaches for testing those therapies. I think that it's important that we, that work continues in developing outcome measures and developing ways in which we can better stratify and better conduct these studies. So I think I'm encouraged by the fact that, we're doing trials today differently than we were 10 years ago. And I think our appreciation for some of the challenges is also, evolving. And I think that, the leadership of individuals like Michael who have pushed forward with these clinical trials has really helped to demonstrate to the field the sort of challenges and obstacles that exist for not just bringing a therapy through the preclinical realm, but in the actual testing of them. In the actual enrolling of individuals into in sufficient numbers. So, I think that it's good that as a field we're talking about it, and I think we are making progress in this area.
Thank you, Brian. Closing statements, closing chapter. The Seattle Science Foundation has been so privileged to host some of the 4 leading minds of spinal cord injury research that make a tangible difference by intervening in terms of pharmacologic treatments, imaging, physiology of spinal cord injury, and surgery. Drs. Harrop, Dr. Kurpad, Dr. Fehlings, and Dr. Kwon deserve a lot of credit for their work and taking the time to tell us all in the world who are going to watch this program about what's going to happen. In closing, with one sentence, Jim, what is your biggest wish? What is your biggest barrier towards successfully completing spinal cord injury research?
I would say my wish is that we continue at the pace that we're going. I mean, we've accelerated amazingly. If I go back to when I started my residency and we had essentially no technology and no use for spinal cord injury. So I'm very positive for the future.
Shekar, Jim talked about stroke and heart attacks being so well recognized and more or less getting a lot of traction. Why are they successful and why are we not doing what they're doing?
I think that's a great question. I think spinal cord injury is still not an obvious and quickly recognized problem. and also to an extent, it is a bit more of an orphan condition compared to stroke and then heart attacks and cancer, for that matter. So I think those are some of the downsides. But on the flip side, I think this is really an exciting time with the intersection of various biological techniques, imaging techniques, and relevant interventions that can capitalize on the information that we're getting from newer techniques. And it's a time better than anything that I've read about in the past when I was training and before that. And so I think the future looks very bright.
Brian, you've recently held a visionary meeting in Vancouver, the Praxis Seminar, which brought together not just researchers and clinicians, not just surgeons and non-operative doctors, but also patients. What are we doing wrong, and what can we do to gain greater public traction so that we don't sensationalize newspaper articles with some mouse studies in a wrongful fashion, but actually make meaningful progress for chronic and acute spinal cord injury patients?
Well, that's a big question, Jens. I think that I think that there's multiple aspects to that, and I think that the Praxis meeting that was recently held in Vancouver really tried to focus individuals' attentions on the values of depth and translation, both in terms of getting novel therapies into clinical trials, and then getting things that were clinically tested out into the hands of those that need it, and the implementation of that. I think that we can learn a lot from our mistakes. I think one of the great things that came out of the Praxis meeting was really getting to hear firsthand what others that have gone before us have found as obstacles to translation. I think that if we acknowledge those issues and recognize their the challenge that they do represent, it'll give us an ability to tackle them. And when Shekar, you mentioned stroke, stroke has gone through 150 clinical trials and been unsuccessful. We can learn from that, and that experience provides us a great opportunity to try to avoid some of the frustrations that have happened in stroke. The things that others that have tried to implement technologies that seem to work in individuals, I think provides us with a lot of insight into what we can do better to merge the science with the technology, with the commercialization that is sometimes required to bring those sorts of novel technologies to market. So I think that there's a lot that we can learn from experiences of the past, both from our field and from other fields. And I think with that, as long as we can embrace those challenges and not try to avoid the fact that it's tough and slow and frustrating, that we can, I think we are in a good position to move ahead with successful innovation.
Thank you, Brian. Dr. Fehlings, Michael, you are the arguably most decorated and justifiably leading researcher for spinal cord injury in our times. You've brought together so many centers, so many projects, and now different countries across boundaries. What is your answer to a patient with an acute spinal cord injury in terms of how far away are we for an actual cure for spinal cord injury?
I think that we are right now in the era where we're seeing the translation of discoveries into the clinical reality. And one of the key concepts that has emerged is time as spine. And it is one of my hopes for the medical community and for society at large to recognize that spinal cord injury is a time-critical event. It needs to be prioritized, and there are interventions that are going to have an effect. there's not going to be one single treatment that is going to reverse all of the effects in spinal cord injury, but everything that we're doing is shifting the curve, is shifting the trajectory of recovery from a prevention, where we're seeing either a reduction in injuries or less severe injuries, advances in EMS, advances in surgery, which has now had an important impact, and I think represents an element of the spine equation. What's needed are greater efforts at prevention. We need to have first-line treatments that EMS can provide. So potentially one of the hopes with riluzole, for example, because it's available in pill form, is that this could be an EMS intervention given by first responders. We then want to be able to more accurately classify the injury and to have focused, targeted pharmacotherapy, biologic solutions that are going to be targeted toward individual types of patients, and then also can be applied in a logical fashion to look at the evolution of the injury. So for example, you mentioned anti-inflammatory treatments versus membrane stabilization. I think that they both have a relevant role, but it's recognized that one has to be very careful with the way you apply anti-inflammatory treatments, because inflammation has both beneficial and harmful effects. And then ultimately going forward, one of the big challenges that we have is to develop effective therapeutic solutions for people with chronic injuries. And this is really one of the big challenges for us to unlock. And here, undoubtedly, regenerative therapies, including the use of biologics and stem cell treatments, among other types of treatments, will ultimately show hope for the future.
Thank you, Michael. Jim, what is the biggest impediment right now in terms of spinal cord injury research? Is it funding? Is it regulatory agencies? Is it egos from various centers or countries? Where's the biggest impediment?
I guess I'll have to say it's probably two big fronts. One is research and continuing with supporting research, and two is getting the patients to the right place. You know, one of the questions that was brought up earlier is we get the patients, but it's amazing. When anyone asks you how many patients you can do for a study, you always say, I can do X. I always cut my numbers in half because you lose so many patients for various reasons. You got to remember, spinal cord injured patient that comes in, it's got to be in the right age group. It's got to have the right injury. They have to speak the right language. They have to be awake, alert. They can't have any concurrent injuries. They can't have any drugs on board. So you're talking about a group of 100 of patients, realistically, in the greatest scenario, you're probably down to about 20% of the patients that can be probably enrolled in the way we presently do an exam and understand the system. If we can go forward, get an MRI, get a biomarker, and use that as a level, you might open up the field greater.
Thank you, Jim. Let me take the occasion of our John Jane visiting professor being with us, professor and chairman of the University of Bochum and the Bergmannsheil Hospital, and the chief of a very revolutionary neurorehabilitation unit. Dr. Schildhauer, a lot of Americans go to Germany for brand new revolutionary treatments, stem cell therapies here and plasma therapies there. Is Germany ahead of America as you see it in the big picture due to less bureaucratic restrictions?
No, I absolutely don't think so. I think we are sitting in a similar boat. We all have our problems with regulatory affairs. We have the problems as the same in Germany as mentioned by Jim, that the patients are coming often late into the specialty units and into the centers. So they have a pre-treatment which is not followed by the rules. and we have to deal with following problems. So I think that is a problem as well. So I would not say that. In every country you have specialty developments which are coming up. Therefore it is, in my opinion, very important that we discuss our results not only on a national basis but on an international basis, and we definitely have to go into multi-center studies.
Thank you, Dr. Schildhauer. I'll ask our chief of our spine service and the president of the Seattle Science Foundation, my partner, Dr. Oskouian, to tell us where to go from here and what your impressions are from this meeting.
Well, I think, I just want to congratulate everybody. I think one of the things I've sort of noticed is that I think one of the things as a medical community that we've done is, we have all our own societies, we go to our own meetings. I think having a webinar like this is really a game changer, both for patients, but just to get the word out there. I think, the more we collaborate, the more we put stuff out there. People really want information, and they're thirsty for knowledge. And I think I just want to congratulate everybody for getting together, and you'll see, over the next 6 months to a year, there's going to be over 250,000 people that are going to watch this, and you're going to help patients, you're going to help physicians. This will be watched around the world, and really that's what this is about. It's about changing one life at a time, and making it a global impact. And so I want to congratulate all you guys for doing this, because these are the type of meetings that push technology, science forward, and really is what I think is what needed in the field.
So in conclusion, I want to thank these 4 great speakers. They're truly the leaders in spinal cord injury research, and their topics were outstanding. I want to thank AO Spine, both North America and international, for funding so much of this important research. ICORD in Vancouver, and the Rick Hansen Institute in Canada, who've really shown the way for us in the US about how to do high-quality research and to involve patients in increasing fashion. I very much hope that our viewers appreciate the tremendous work and the dedication of these researchers in terms of trying to make their lives better. And we're really looking forward to next steps taken together in a multinational and inclusive fashion. Thank you all very much.